So thank you so much, Kenta. Yeah, that is really amazing of you. Yeah, so we are going to look at the measurement of socioeconomic inequalities in health. Specifically, yes, inequalities occur in very many ways, and there are so many types of inequalities. But for this particular session, we are focusing on socioeconomic inequalities in health. So as an outline to this session, so we shall have an introduction and definitions. Then that will be followed with the reasons why we measure socioeconomic inequalities, the common indicators that are used to measure socioeconomic inequalities, and then also health outcomes. We shall look at absolute and relative inequalities, a bit of definitions, and then look at concentration indices, and lastly have a discussion. So the reason why we are having this seminar, first of all, I would want to let everyone know, is for us to share information as peers and also create a network. And therefore, please, at the end of this session, so I'll do the presentation first, but then at the end of the session, feel free to share what you think probably is helpful to the peers that are attending this session. So when we talk about inequalities, so majority of the time we focus on the differences within our societies and communities. In this particular context, so inequalities are systematic differences in health of the people occupying unequal positions in society. So the occupation of unequal positions in society leads us to have different health outcomes, which is unjust and unfair. So majority of these differences in health outcomes are observable and also can be traced back to the differences in socioeconomic status that exists amongst our society. So health inequalities are unjust. We need to agree on that, and then also are preventable, so we can avoid them. They are not natural in terms of existence, and therefore a lot can be done. And this gives us the urge to do, first of all, to quantify them and then suggest ways on addressing them. So the reasons for measurement of socioeconomic inequalities, we need to identify those that are probably benefiting from the society more. But then the most important part are those that are left out, the vulnerable groups who are losing out. So yes, who is benefiting more? That is okay in some cases, but the most important part in terms of health, we need to leave no one behind. And therefore, we need to identify people whose health needs to be improved too. So health, the measurement of socioeconomic inequalities also helps us to understand the trends of these inequalities within our societies, and therefore gives us a good platform to measure the impact of policies and interventions that we may implement. So in terms of relevance of socioeconomic factors, so here we have an illustration, a framework that shows the interrelationship between some of the socioeconomic status factors and our health, both from individual level to the overall society or community level. So what are some of the indicators that are used to measure socioeconomic positions? So some of the common indicators that we use are education status. For example, how many years of education has someone had. So how many, sort of like what levels of education has someone achieved. When you look at occupation, so what is their social class, type of employment? Is it manual? Is it white collar job or blue collar? Among others. Then we look at the income of an individual, how much they bring in, but then also income. When you look at the financial status of someone, we usually prefer to use wealth because income can be deceptive in some cases. And then lastly, there are also aggregated measures that we could use. For example, area-based deprivation indices. So in terms of health outcomes, so some of the health outcomes that we use include mortality, which could include all-cause mortality, all specific cause mortality. So for example, maybe if you're looking at a specific cancer, so how many people are dying of that particular type of cancer, for example, pancreatic cancer. Then we can talk about morbidity, where we look at incidence and prevalence of disease, or the occurrence of disease, where you look at the number of cases, which kind of people are getting which disease, and how is that distributed within the community across the different socioeconomic status. Then we have self-rated health. So for example, we have health-related quality of life, among other measures that could be used in self-rating health. Then health behavior, so which could include physical activity, smoking, diet, among others. Then access and use of health facilities, all health services. So this access could be physical access, it could be financial access, and also the physical access includes, for example, geographical location, where you have the mechanism of transport to the health facility. And then the actual use of the services. Do you receive the same services depending, no matter your economic status, for example, or do you receive different services? So probably because you have more money, you can purchase more, or because you have less money, then probably you can forego some of the needed health facilities or health services. So in terms of types of inequalities, so inequalities could be looked into as absolute or relative inequality. And with absolute inequality, as the word goes, we look at the differences in health between groups. And this is using absolute sort of like terms or absolute measures. So for example, mortality rate differences amongst groups. But when you talk about the relative inequality, then we look at proportionality. So we look at the proportional difference amongst these groups. So both measures are important, and it is good to have both reported within a study or within a given research project. So the methods that we can use to measure socioeconomic inequality, so these are vast and can be classified. In this particular case, I classified them into three. So where we have measures of association, measures of potential impact, and then the ranking-based indices. So the measures of association include odds ratios, regression coefficients, we have correlation coefficients, among others. So a majority of the time, these measures, we compare groups, for example, the intervention group versus the control group, or a specific groups of different socioeconomic status to see their relationship with each other. And then we have the measures of potential impact, especially at the population level, for example, population attributable risk. And then we, lastly, which we are going to focus on more, are the ranking-based indices. So these include concentration index, for example, and then also the corrected concentration indices, as we shall see. So one of the ways we can measure inequality is the use of concentration indices. But the concentration indices can be derived from concentration curves. So the concentration curves give us a graphical representation of the distribution of the benefits or losses across socioeconomic status ranked individuals or areas. So we have to rank the individuals or areas within our study along their socioeconomic status level, starting from the poorest to the richest all the well-off. And then we also plot the cumulative proportion of health outcome variable against the cumulative proportion of the population ranked by socioeconomic variable. As we have seen, the socioeconomic variable could vary. It could be anything that sort of like shows status within the society. So an illustration of a concentration curve. So we can see in this diagram that we have a pink line, which is at 45 degrees from zero or from the intersection of the X and Y axes. So this, all that is the equality line, all line of equality, whereby there is no inequality within a given group. And then the concentration curve, which is the line in purple, so that actually shows us the distribution of the benefit within the group of interest. And the benefit is sort of like proportional. It is shown in proportions. So that's why we are having the x-axis, so showing the proportion, the cumulative proportion of the population, which is ranked by the socioeconomic status using a variable of choice. And then on the y-axis, we have the cumulative proportion of the health variable, which could be, for example, specific cause mortality, it could be immunization, it could be anything that is of interest to the study. So in the graph before, so the curve was below the line of equality. And when the concentration curve is below the line of equality, then it means that the inequality is pro-rich. So that indicates that the rich actually benefit more in terms of the health variable that is being assessed. Whereas when the concentration curve is above the line of equality, for example, as indicated in the projected image, so then it means that the inequality is pro-poor. So this means that the poor people are getting more of that that is on the y-axis. So how do we check significance or dominancy of inequality using concentration curves? So when you have a curve with you, or you have developed a concentration curve, so you can visually inspect the curve to check whether actually the inequality is significant or not. This could be done by looking at whether the concentration curve, crosses the line of equality within the graph. Because if it crosses, then it means that the inequality is not significant. Yes, it exists, but statistically, it may not be significant. And then also the beauty with this, there are some data packages which you can use to actually check whether the line goes across the graph or not. I mean, across the line of equality or not. So this is where we have one concentration curve within the graph. But in the event that we have more than one concentration curves within the graph, for example, you are comparing countries, inequalities in different countries. So in this particular case, you can still use the visual inspection. And then in terms of the comparison, so we can look at the different curves in relation to the position of the different curves in relation to the line of equality. And the farther the curve is from the line of equality, the more the inequality. So let's see an example here. So this graph is taken from a WHO report 2013, which compared the inequalities in Bangladesh and Egypt. So looking at the births number accumulative, the fraction of births attended by skilled health workers within the two countries. And we can see that in this particular case, Bangladesh seems to have more inequality compared to Egypt, given the positions of the airlines. So that is just an example to show an illustration of this. So then we move on to the concentration index. So the concentration index is of course a bivariate rank dependent variable where you have sort of like ranking of the population along a socioeconomic variable. And then also you have the health related variable, all health outcome variable of choice. So this actually is defined as the area of the area between the concentration curve and the line of equality. So it is when you get the area of the concentration curve between the area of the concentration curve between the concentration curve and the line of equality. So you have to multiply the area by 2 to get the index. So, and it ranges from -1 to 1, where 0 is no inequality available. And then when it is positive, it is pro-poor, pro-rich, sorry. And then when it is negative, it is pro-poor. So there are some bit of advantages and disadvantages to this. So the advantages of using the concentration index, so it puts into consideration the whole distribution of the population, all the sample in consideration, and then also shows the direction and magnitude of the inequality. So compared to the graphical concentration curve, so in this particular case, you can easily tell the differences in magnitude in case they are close to each other. It may be very difficult for you to distinguish the inequalities using a concentration curve in case they are quite similar between countries or observations. But in this particular case, it is very easy to sort of like tell that. And therefore, this concentration index helps us to compare between different areas, groups, and countries, among others. So the other advantage of the concentration index, so you can relate it to the concentration curve, whereby in case the area is big, within the concentration curve, you can check it to the concentration index and see, is it really reflective? Of course, they sort of like rhyme, and therefore it's a way of checking. Then disadvantages of it. So it is very much mean dependent. So for bounded outcomes, therefore it may be problematic when you are comparing between countries over time. And then also it assumes that the health variable is a positive measure. So, but sometimes it may be ill health, for example. So it may be a little bit difficult to tell the distinction between the two. So this is why we have the corrected concentration indices. So the corrected concentration indices are vast. The number of indices that are used out there, but some of the common ones is the Wagstaff corrected concentration index, and then also the Agas corrected concentration index. So Wagstaff developed that index. However, it still has some bit of challenges, especially with the means. and therefore Aga's index is more preferred ever since he published that paper in 2009. So I'll give an example of a study where we used the concentration indices to measure inequality. So this is a study that was done in Zambia to investigate the level of inequality in the current use of modern contraception and unmet needs of contraception among sexually active women of reproductive age in Zambia. Yeah. And we compared 3 rounds of the DHS. The uh, the the reason for conducting this particular analysis was to inform the family planning policy. So this was done in conjunction with the Ministry of Health in Zambia. So we had women of reproductive age and trying to see whether they use modern contraception, and those that use modern contraception, how is the distribution of modern contraception across their different socioeconomic status. So we use the wealth index, which is derived by the DHS using 15 variables of standards of living within the country. And this helped us to rank the population, all this particular sample of ours that we included in the study, from the poorest to the richest. And what we got is that when you look at modern contraceptive use, so it was pro-rich. So because the concentration curve is below the equality line. And the interesting part was when you just inspect or visually inspect the curves, so from A to C. So where A was 2007, B was 2013, 2014, and then C was 2018. So you could see that visually there is some bit of differences across the three graphs. So with the area between the equality line and the curve decreasing over time. So when you look at the index itself, the Aga's index, still it shows a similar trend in this particular case. So this is one of the ways that we used it. And then when we looked at unmet need, now whereby we were looking at an element of inequity. So in this particular case, unmet need for modern contraception is where someone would want to stop having babies, but unfortunately, they're not using any form of contraception. So when we plotted that, we realized that actually it was more poor. So more poor people actually got all experienced unmet need for modern contraception, which actually makes sense anyway. So which was expected in this particular case, given the distribution of modern contraception across the different social health economic status. In this particular case, the wealth index. Yeah, so that is all that I had to share with you. This is quite foundational in terms of measurement of socioeconomic inequality. So the reason for this, it was to give us some bit of foundation. And in the next series, we are going to have some in-depth analysis of the different indices that are used. Why are they different? How are they different? And which one should we use? And then after that, we shall also have another session that focuses on decomposition of the index, where we try to find the drivers of the inequality that has been measured or has been found. So we did receive some questions within when you are signing up for the seminar, and there were a number of questions, but majority of them sort of like were concerned about the usability of this evidence. So first of all, how can it be used in real life? And then how can we promote it? So those are questions that we can discuss at some point if there are, along with other questions that people may have. Yeah. So do we have anyone who would want to contribute? You can maybe type in the chat or in the question and answer chat.
And if anyone has any other questions, they are more than welcome to write anything.
Exactly, yeah.
In the Q&A section.
So one of the things that comes to mind when we say how is inequality evidence used in policy making? So Kenta, what do you think? Maybe before I give my view on that.
Yeah, thank you. I had this question as well because in my field of research, also once we find like inequalities, we say something in our research article that first of all we found this inequality and we have to do something, but we rarely see the actual like actionable plan, what we do based on these inequality that we find. So to me, honestly, I have no idea what how this kind of evidence is used in policy making. And I was very curious to learn from you, Joseph, since you've done this real world research about modern contraceptive use in Uganda or Zambia, I'm sorry. And then if I understood correctly, you have seen the decreasing trend of inequalities over time. But by collaborating and working closely with policymakers and also practitioners in Zambia, working on this contraceptive use, how did you communicate this research findings with them? And then how did they appreciate or how did they make a use of it? If you could provide any reflection on that.
Yeah, so thank you so much, Kenta. That's really thoughtful. So when you look at the Zambian scenario, so there was need to understand whether the interventions that had been implemented over time had actually reduced on inequality, and the focus points were in the rural areas, especially women in the rural areas, and also women that are of lower education status, to check whether their use of contraception had either increased or decreased, because Zambia had focused so much on promoting the use of modern contraception, I think, in those rural areas. So which was quite an investment with cooperating partners, for example, USAID, among others. So in this particular case, we found that actually the inequalities are reducing. But it was very interesting that when you look at education, so people that were, I think, secondary school level used more contraception than the people that were very highly educated, at least who had a university degree. So which was quite interesting in that particular case. So this was presented to the stakeholders, the results of this, of the study. However, as you mentioned, I think it is kind of difficult in terms of action, because majority of the time, I think as researchers, we tend to focus more on just producing or just looking at your problem. And when it comes to translation, we tend to sometimes either not follow up to check, because sometimes these ministries just move on with maybe there is someone who has picked it up within the ministry, and then they inform there are these interagency meetings that usually take place in these countries, which sort of like, and the ministry usually directs the agencies or the cooperating partners on which area to fund. So it is something that probably I need now to follow up. That's interesting, Kenta. I don't know what exactly how that was used, but at least one thing that I know is that the ministry is informed about it. Yeah.
Great, thank you, Joseph. Now we got the one new question. I can read it out loud. Well, two questions, but first of all, how do you ensure that policymakers align with your results? Thinking of third world countries where governments might deny that there is inequality in communities.
That's a very difficult question because if someone's denying that it doesn't exist, but usually some of these truths or facts, I think it takes time for people to accept. Sometimes we live in denial, especially if there is some bit of conflict of interest for the policymaker, especially when it comes to the politicians, whereby they need to show that what they invested in actually resulted into something very good or something impactful. So in the event that that is not the case, then they're a little bit hesitant to accept what you are presenting or what you're reporting. But that said, I feel still there is room to interact with them. It may take time, but if you sort of like present this information in a simple and straightforward way, for example, through policy briefs, you engage other stakeholders that work with the political establishment. So you find that there is always room for discussion if you don't pin them down that it is their responsibility or it is their fault. So as long as the politician is not taking the fault, I think their chances of receiving this information and acting on it are quite high. But if you come probably with pointing fingers, then sometimes they are likely to push back on certain things. And that could lead to maybe not so much of them acting on the evidence. That's my thought. Yeah.
Very interesting, Joseph. So that to me, that sounds like we can have another independent session about that, how to communicate scientific results with stakeholders to actually implement what you find, or to collaborate with those stakeholders. So next, I can read another question. Should the data be longitudinal or survey data to measure socioeconomic inequality, or even repeated cross-sectional data?
Yeah. So for this particular case, we used repeated cross-sectional data. We didn't use really, I wouldn't call it longitudinal, because this was survey data that which surveys were done at different points in time. And this means that we are not, although we are sampling from the same population, they are not the same people that we are actually that we are working with, all investigating. So I would say for this particular case, we used cross-sectional studies. But when it comes to longitudinal studies, there are other methods that you could use for this. And then also in terms of longitudinal studies still, so there is also other approaches that could be used, but this is an area that probably we can discuss in one of our future sessions to actually look at it in detail. Yeah.
Great. Next question is, have you come across scenarios of within group inequality, and do these indices cater for this?
Yeah, so within group inequalities, yes. So there are those scenarios, and there are different approaches to that. We shall actually in our coming sessions, because I feel inequalities, majority of us measure them in, I would say, majority of the papers actually have an element of reporting inequalities. But when it comes to these indices, so it would be nice to elaborate more on within group inequality, I would say. Yeah, it is possible, but not so clear cut. Yeah. Mm.
I have a follow-up question on that, or it could be just apart from these questions. So when in your this field of research, when you look at inequalities, do you also see like the causal relationship between a certain socioeconomic factor and health outcome, or more like you simply investigate inequalities in terms of health outcomes?
Yeah, so for this particular level of the seminar, so we focused on just trying to estimate the actual inequality. Yeah, not the cause of the inequality. Yeah. So that is something that we need to be very clear on, all about. But there are methods that we can use to try to identify the causal link and the extent of that causal link, or the strength of that causal link between certain factors and the actual inequality as measured. That is why we need decomposition. For example, Gwain's method. Yeah. So we shall invite Gwain at some point to give us some bit of explanation on his method and how you can use decomposition to actually identify some of the likely causes. Yeah.
Great, thank you. Another question. How do policymakers address pro-poor index outcomes? Are there some examples of pro-poor outcomes?
That's a very good one. Yeah. So for for the example that I shared, so the pro-poor outcome in this particular case was negative. So it wasn't positive. So because it was more about eliciting need for modern contraception that is unfulfilled. So, but in terms of looking at insurance, maybe, so whereby if you are having an insurance, if you are having a government insurance scheme that focuses on poor, that subsidizes the poor, so majority of the time you find that government schemes in some countries, where a country has more than one scheme, you'll find that if you are looking at inequality in accessing primary care services that are covered under the scheme, you may find that maybe the poor people access some of these specific services more. But when you move into the specialized services, it may be different. So I can't give you a clear example in real life that I've seen in that way, but it's something that I can go and read on and see if there are any. But that is an hypothetical scenario that I was thinking about. Yeah.
Great. Another question. How can we ascertain inequalities in health interventions where there is no universal health coverage.
Could you repeat yourself, sir?
How can we ascertain inequalities in health interventions where there is no universal health coverage?
Mhm. So maybe if the participant could explain more on the question.
Yes.
Or if someone else maybe knows something, please feel free to respond to any questions if you want, please. That would be helpful. Ascertain inequalities in health interventions where, because what is universal health coverage? With or without universal health coverage, I think some of these inequalities occur. Yeah. So, but the extent of the inequalities varies depending on the interventions that are sort of like being implemented. So I would say when there is no universal health coverage. Now, that universal health coverage, first of all, in itself, it is a little bit from my point of view, is hypothetical. So it is very difficult to achieve 100%, right? So usually there will be a last mile that you may not achieve. So I'm thinking that in an event where you have greater coverage of services, so there is likely to be less inequality in some cases. While if there is no universal health coverage whatsoever, then I would say the inequality will be more profound because you would assume that some people, those that can't afford, for example, to access services, may never get them or they forego them. And therefore, that affects their health situation and health status more drastically, I would say. Yeah, so we have something from Derek. So who says that many of the LMICs do not have universal health coverage, and clearly many outcomes are indicative of health inequalities based on socio-economic class. Yes, I can't agree enough with you, Derek. That is the case also that I would think about, yeah. But also sometimes we think about the low and middle income countries as countries that have a lot of inequalities. But you'll be shocked. In some cases, you find that high income countries also have really unimaginable inequalities. For example, when you look at our brothers and sisters in the US, so the inequalities there are quite vast in terms of access to healthcare. If you don't have insurance, for example, it may be very difficult for you to get services. You don't have Medicaid or something. And then also there are these insurance packages that may not cover certain health facilities or certain health services. And that in some way, of course, affects the utilization of services. Yeah, so any other questions? All suggestions, please keep them coming in case you have any suggestions or ideas. So,
one last question Derek has given. The example of the graph comparing Egypt and Bangladesh.
yes.
How do you ensure that the socioeconomic classes are equivalent?
Very good. Yes, I think, Derek, that is a very good question, 100%. For this particular data source, so first of all, there are things that we need to pay attention to. One are the socioeconomic the variable that is used to measure socioeconomic status in this particular case. So they used the wealth status or wealth index for the different people within the country. So we need to be sure that actually it included similar variables in establishing that wealth index, because an index, of course, has maybe other factors that are considered in this particular case if it is the DHS. So we have to ensure that they are similar or they are the same. So they are the same variables that are used to come up with the index. And the ranking, of course, is what is important, Derek, here. That's what I can say. So if you rank people from the poorest to the richest, that is something that is very important. And we can compare, although the comparison, of course, has a margin of error, and we can use standard errors to sort of like try to see which country has more dominant inequality. So that is something that probably we can think about doing probably in the future. So using standard errors to determine the differences in inequality amongst countries using concentration curves. Yeah. A very good question, Derek. That is really lovely. It's a very good question. Yeah.
That's all.
Yeah, so I think with that, I would want to. Do you have a last word, Kenta?
No.
Yeah, so I would want to thank each one of you that attended this session. So we greatly appreciate your presence. And please, in case you have any questions, in case you have any additions, keep in touch. You can send me an email. You feel free to reach out, and we can have further conversations in other areas. So I'm more into health economics. So in case there are any topics that you're interested in, please feel free to share them. And then my dear friend Kenta is more into epidemiology. So feel free, in case you have any epidemiological points of discussion, please get in touch. The other sort of like disclaimer is that we are not experts in this, so we are here to share our understanding of things, and therefore we welcome critique. We also welcome additions and to sort of like take this conversation forward. So thank you so much, everyone, and have a lovely rest of the day.